I'm Shaji Kumar. I'm a professor of medicine at Mayo Clinic in Rochester, Minnesota, and is a part of the myeloma group at Mayo Clinic. I'm here at the annual meeting of the American Society of Hematology in New Orleans, and I'm presenting some data regarding the comparison of two different regimens that we commonly use in treatment of newly diagnosed multiple myeloma. Now, as a background, the proteasome inhibitors has been a mainstay of therapy for multiple myeloma. And we have a lot of experience using bortezomib as part of different combinations in the initial therapy of multiple myeloma. Specifically, the two most commonly used combinations in this country currently is the one that combines bortezomib with cyclophosphamide and dexamethasone, or combines bortezomib with lenalidomide and dexamethasone. Now, a few years ago, we did a randomized phase 2 trial that looked at these different regimens in the newly diagnosed patient population at the same time, which was called Evolution study. In that study, what we found was the combination of bortezomib, lenalidomide and dexamethasone was fairly comparable to the bortezomib, cyclophosphamide and dexamethasone. And the implications are manifold. I think the most important is the fact that a combination like cyclophosphamide, bortezomib and dexamethasone tends to be a lot less expensive than when you use the lenalidomide, bortezomib and dexamethasone. The second important implication is that if we can show that these are comparable, we could use one after the other instead of trying to use everything at the same time. And that has significant implications on the cost of therapy, and especially in the coming times where the cost constraints are really going to play a role in our therapy determination. So what we did was try and see if we can validate what we found in the Evolution trial in a real life setting. So we did this study looking at a group of patients at Mayo Clinic and a group of patients from a community oncology setting who were sites within the US oncology group. So we took roughly about 100 patients who got lenalidomide, Velcade and dexamethasone, and about 100 patients who got bortezomib, cyclophosphamide and dexamethasone. And we basically collected the data on what kind of responses did these patients get, what was the progression-free survival, what was the overall survival related to these therapies. The interesting finding from our study was the response rates were very similar for patients getting the bortezomib, cyclophosphamide, dexamethasone and patients getting bortezomib, lenalidomide, dexamethasone. The two patient groups were fairly similar in terms of the type of characteristics that we would look at baseline, with the exception that there were more patients with renal disease in the bortezomib, cyclophosphamide, dexamethasone group. The response rates were similar, including the deep responses. The progression-free survival was similar, and the overall survival was similar between the two groups of patients. And again, supporting the data that we got from Evolution that these two regimens are fairly comparable in terms of their efficacy. We did not really see a significant difference in terms of the side effect profile between these two medications. And when we look at the cost that's incurred, as you would expect, when you add the lenalidomide to the combination certainly becomes more expensive. So while neither the Evolution study nor this retrospective study is confirmatory in the true sense, because they are not really randomized trials, I think the sum total of the evidence provides us with more data to support the notion that these two regimens are fairly equivalent, and we can look at both the regimens in a comparable fashion and make the decision as to which one to use, maybe in terms of the risk stratification or maybe in terms of what is the cost of care involved. But it certainly opens up the question as to we should be asking these kind of questions in the phase 3 trials. So I think going forward we are going to see more and more of these type of studies where we would actually be looking at the existing data, mining them to see what is the cost effectiveness of a particular strategy, and maybe we will look at a bunch of different strategies and decide, okay, these two different strategies seems to be the most promising based on this kind of comparative effectiveness research, and maybe decide this is the question that we need to move forward to a phase 3 trial. And that also leads to significant cost savings, because a phase 3 trial costs millions of dollars.